Hello there. My name is Deanna Radford. I'm a nursing student at Bluefield State College. The objective of this video is to discuss an ethical issue that has raised several questions over the years. Do nurses and physicians provide the appropriate and indicated care and treatment when a DNR order is in place? There have been many studies on this issue. The goal of having a DNR order is to respect patients' autonomy, to reduce harm done to patients, and to decrease the use of futile and costly medical care. The legal definition of DNR means do not resuscitate, not to initiate CPR in the event of a cardiac or pulmonary arrest. Competent patients have the right to refuse CPR after they have been informed of the risk and benefits involved. This is what a DNR card looks like. DNR does not mean no care. DNR decisions should reflect what the informed patient wants or would have wanted, including communication about the end-of-life wishes. This is best done before a life-threatening crisis occurs. Good open communication is crucial. End-of-life discussions increase anxiety, increase stress with patients, family, and staff. As an ICU nurse, this topic has interested me for some time. Nurses are in close, continuous contact with patients, often able to discuss this. No one finds it easy to talk about death and dying. We need to understand what the patient wants, then document and discuss this with their physicians. There are many handouts and booklets to assist healthcare staff in avoiding any DNR miscommunication. This is an example of one that you can find at the hospital or your local physician's office. The interpretation of what a DNR order means may vary between nurses and physicians. Nurses play several roles in DNR decision-making. We are involved in the initiation of the DNR discussion, and we act as a mediator between patients, family, and physicians. We educate and evaluate the readiness for decision-making and provide supportive care throughout the process. Some nurses find it rewarding to give close physical and emotional support at the patient's end-of-life stage. Nurses' perceptions toward DNR varies along with end-of-life care. Some believe it is sacred and should be preserved at all costs. Some believe in natural and peaceful death is preferably. DNR order should not dictate or alter the course of treatment. This may lead to inadequate or delayed treatment of potentially curable illnesses among patients with chronic health conditions. Personally, having lost several immediate family members, including my father at age 56, end of life is an important part of general patient care. Discussions about end-of-life wishes have empowered patients and families to become more involved in their own care. My personal experience helped me to focus on what the patient wanted. As an ICU nurse, I felt my father's terminal lung disease would not have benefited from being intubated. At the time, he was competent and wanted intubation for a brief period of time. Experiencing his last month in an intensive care setting made me more appreciative as a nurse of my family, patients, and their families. There are always two views on an issue, pros and cons. Some studies agreed with the decrease in care of patients with a DNR order. Most basic care was consistent. Good hygiene, morning care, turning, repositioning, infection management all stayed the same. Some studies did suggest that the intensive care settings was a decrease in invasive and aggressive care with patients who had a DNR order. The orders serve to increase the dignity of death among terminally ill patients. While patients with a DNR order may not receive as many investigative or treatments as those without an order, this does not necessarily mean worse quality of care for this patient. Prior studies note that a patient with a DNR order receives more bedside nursing care, which increases the patient's satisfaction. Patients with a DNR status are often less likely transferred to an ICU. The presence of a DNR may affect the doctor's willingness to order a variety of treatments, like blood cultures, blood transfusions, invasive procedures, cardiac function tests, all of which have nothing to do with CPR. It is often disturbing for healthcare providers to perform CPR on a patient with advanced illnesses, old age, dementia, or even in a debilitated state. CPR may be a harsh and traumatic procedure. It can cause potential harm and suffering to the patient. Its effectiveness may often be overestimated and not always medically indicated. The fact that CPR may be ineffective does not mean that the interventions will be. Often we may be overly aggressive. The value and preference of the patient's wishes and desires is what is most important. The less aggressive treatment may represent the appropriate level of care for this patient. DNR orders theoretically serve to improve the dignity of death among terminally ill patients. But a chronic health patient, this may lead to inadequate or delayed treatment or potentially curable illnesses. Almost all medical staff in all the studies that I researched felt that DNR was necessary in relationship to patients with a terminal condition. Some of our own emotions and experience influence us as healthcare workers. Some studies show critical nurses give less aggressive care to patients with a DNR order. One study suggests that views were seen differently by the field of medicine healthcare members are from. Like internal medicines interpret DNR as just that, as only resuscitation, where oncology and critical care may view DNR more toward palliative care. Some felt that the DNR orders had no effect on everyday care and treatment. There is little research into the development of ethical guidelines with DNR orders. The biggest source of confusion is an overinterpretation of what DNR means. DNR orders address only whether to initiate CPR in the event of an arrest. When we allow DNR orders to carry more extensive meaning, then we become confused and ultimately put patient and families at an avoidable risk of suboptimal care. In conclusion, the effects this has on nursing and healthcare varies differently between patients, between different perspectives of healthcare workers. There is more discussion and education needed for the interventions guidelines for end-of-life nursing. Palliative care, comfort measures, allowing a natural death. These orders are not seen as much as DNR orders. Our ethical principle is to do or promote good, prevent harm, and to remove evil or harm. Thank you, and I hope this is very beneficial to you.